So good morning, all. We are into exciting finals. I would like both team to introduce yourself to the audience, and then we will start off as early as possible. I think we can start from Kottayam.
Good morning, we are Team Kottayam. I am Sophia.
My name is Amit.
Salma.
Shivani.
Calicut.
I'm Dr. Rajit Balachandran.
I'm Dr. Anju Aravind.
I'm Dr. Jerry George.
Myself, Dr. Yadu Krishna S.
Okay, thank you all. All the very best to each team. So you know what it means because we have reached this level. Let us start on. I think who is going to present first? Kottayam. You're going to present first. Okay, go ahead. Can we have the slides on? Timing ready? Yes, let's start off. You can't see that? Yeah, can you just see? It is not visible on the monitor.
The format will be the 10 minutes for the case presentation and 15 minutes for the discussion. At the 9th minute, there will be a beep sound. You will have an alarm, and during the 14th minute, similar one will be heard for the discussion also. So, total 25 minutes for each case.
Okay, you can start now. The time starts. Timer ready? Okay, let's start.
Good morning, we are Team Kottayam. We would like to present our case. Our case, a patient of age 45 is a teacher who is coming from Kottayam. She complains of dilated veins in the left lower limb for past 3 years with discoloration of skin over left angle for the past 6 months and the presence of non-healing ulcer over the inner aspect of left angle for past 2 months. Patient was apparently well until 3 years ago when she noticed dilated veins on the inner aspect of the left lower limb. It was insidious in onset and increased in size on prolonged standing or walking and decreased on lying down. It was associated with intermittent episodes of dull aching pain since 1 year in the left leg, which aggravates on prolonged standing and relieves on lying down or elevating the limb. It was not associated with night cramps. She also complains of blackish discoloration of the inner aspect of left lower limb and angle over the past 6 months. It was insidious in onset, gradually progressing and associated with itching. She then noticed an ulcer over the inner aspect of left angle of the size of a coin, which gradually increased to the current size over 2 months. It was insidious in onset, no history of preceding trauma. It was associated with watery discharge. There is no history of edema or pus discharge or fever, no history of bleeding from dilated veins or the ulcer, no history of trauma or bursting type of pain in the lower limb, no history of prolonged immobilization, no history of intermittent claudication or rest pain, no history of abdominal symptoms, no history of similar complaints in the right lower limb. Past history, She is having no known comorbidities, no history of previous surgery or long-term hospitalization, no history of use of OCPs or hormonal treatments, no history suggestive of a DVT episode in the past, no history of penetrating trauma to the limb. Personal history, she is taking a mixed diet, sleep is normal, normal bowel and bladder habits, she does not have any addictions or allergies. Menstrual history, she attained menarche at the age of 15, regular cycles, P2, L2, normal delivery. No similar complaints during pregnancy. Family history, no history of similar complaints in the family. Treatment history, she has been using compression stockings irregularly for the past 2 years. The ulcer was managed with daily dressing for the past 2 months, with which she was found some relief. However, the ulcer did not heal completely. Summary from my history, a 45-year-old teacher with no known comorbidities presented with complaints of dilated veins over the left lower limb for 3 years and hyperpigmentation of the left angle for past 6 months and a non-healing ulcer over the inner aspect of left angle for 2 months with no significant past or family history.
Our patient was examined after taking verbal consent in the presence of a family attendant. She was conscious, cooperative and oriented. Karnofsky performance status was 100. And our patient was obese with a BMI of 28.6, obesity class 1. Heart rate was 86 beats per minute, regular rhythm, normal volume and character in the right radial artery. Blood pressure was 138/90 millimeters of mercury in the right brachial artery in supine position. Saturation was 98% in room air and respiratory rate was 16 cycles per minute. There was no pallor, icterus, cyanosis, clubbing, edema or generalized lymphadenopathy. On inspection of both the lower limbs, our patient was examined in standing and supine position from umbilicus to foot. Right lower limb appears to be normal. Attitude of the left limb is normal. There is no deformity. Multiple dilated varicosities were seen in the region of the great saphenous vein in the lower part of the thigh. There was no varicosity seen over the lateral and posterior aspect of the thigh and leg, and no varicosity seen over the lower abdomen. Skin is stretched and dry with hypopigmentation and eczema seen over the left ankle and medial part of the leg. An ulcer of size 4 into 3 centimeters present over the left gaiters area. Margins were well defined, sloping edge and pale granulation tissue over the floor. Serous discharge was seen. Skin around the ulcer is hyperpigmented. There is no redness or pus discharge. On palpation, there was no local rise of temperature or tenderness. Limb girth at the calf was 24 centimeters in the right lower limb and 23 centimeters in the left lower limb. An ulcer of size 4 into 3 centimeters was present over the gaiters area. Margins well defined, sloping edge and pale granulation tissue over the base. Base is underlying bone. Skin is thickened around the ulcer with lipodermatosclerosis. Range of motion in the left ankle joint is slightly restricted compared to the right ankle joint. All peripheral pulses were well palpable and the right lower limb was normal. There was no inguinal lymphadenopathy. Other tests, we done a Brody-Trendelenburg test. Test 1 and 2 was positive. Tourniquet test, dilated veins were seen between tourniquet 2 and 3. Modified Perthes test, there was no pain. Fegan's test, defect in deep fascia appreciated 4 centimeters below the knee medially. Morris's cough impulse, there was no impulse felt. On percussion, Schwartz test was done and there was no impulse felt at the saphenofemoral junction. On auscultation, a Morris's cough impulse was done and no murmur was heard at the saphenofemoral junction. No bruit over the varicosities. Abdominal examination, there was no palpable mass or organomegaly, no shifting dullness or fluid thrill. Hernial orifices were normal. Digital rectal examination and PV examination was within normal limits. Other systems, a respiratory system, air entry was bilaterally equal, normal vesicular breath sounds were heard. And cardiovascular system, S1, S2 was heard, there was no audible murmur. Summarizing, a 45-year-old lady, teacher by profession with no known comorbidities, presented with complaints of dilated veins over the left lower limb for 3 years, hypopigmentation of the left ankle for the past 6 months, and a non-healing ulcer over the inner aspect of the left ankle for 2 months. On examination, she was found to have varicosities in the region of GSV, hypopigmentation and venous ulcer over the gaiters region with positive Trendelenburg test 1 and 2, tourniquet test and negative modified Perthes test. Diagnosis, chronic venous insufficiency of the left lower limb of primary etiology involving the great saphenous vein with saphenofemoral and perforator incompetence, with a non-healing ulcer and no signs of deep vein thrombosis. CAP classification C2, 4A, 4B, 6, EP, ASP, and PR.
So over to you for discussion.
It was a very good presentation. So, what are the points in favor of your diagnosis?
So this is a 45-year-old female patient. She has complaints of dull aching pain in the lower limb with varicosities, which was present on history and examination. An ulcer is also present on the gaiters area. So the history and examination together with the test done suggests of a varicose vein history for a past 1 year with an ulcer for the past 2 months.
Okay, in your case, the patient is a female. So, is there any variation in occurrence of varicose veins with gender?
Actually, 10:1 ratio is there when comparing to the female sex and male sex. Also, if patient is on OCPs, also there is a risk factor in case of females.
Could you just add on, like, what do you think would be the cause for the female preponderance for varicose veins?
Presence of progesterone is also a risk factor. Progesterone will cause venodilation and it will
By
also
muscle relaxation. Okay. In the past history, what is the significance of asking for any history of injections for varicose veins or surgery for varicose veins?
Any previous surgeries that can cause recurrence of varicose vein, like previous endovascular procedures or any open surgeries or foam sclero is also a risk
Foam
factor.
sclerotherapy can also cause thrombosis, and this will lead to secondary varicose veins.
Why do you say your ulcer is a venous ulcer?
It's present in the gaiters area, which is the area 1 hand breadth above the medial malleolus. There is a presence of multiple perforators, so there is high chance of formation of ulcer in that particular area. My patient also has an ulcer in that area.
Okay, what is the, how is champagne bottle appearance formed?
It is due to chronic venous insufficiency when there is fibrotic thickening in the distal end that will cause an inverted champagne appearance, thickening of the skin and obliteration of the fat.
And also there will be
There will be contraction of the tendon of Achilles also.
and also there will be calf muscle hypertrophy due to venous congestion.
Moving on to the examination, is there any clinical test to assess the deep venous system patency? Did you do any test to perform the deep venous system patency?
We did the modified Perthes test in which after taking consent and explaining the steps to the patient, in standing position a tourniquet was applied just below the saphenofemoral junction and the patient was asked to walk quickly. If the patient develops pain, it means the deep vein incompetence is there or deep vein thrombosis is there. In our patient, pain was not present, so deep vein system is intact.
How is there hyperpigmentation and itching over the area?
It's due to venous hypertension. It will cause leaky gap junctions, which results in the passage of RBC and causes lysis, results in hemosiderin deposition on the skin, which causes itching and also pigmentation.
Okay, so you have to identify the SFJ for doing the modified Perthes test. So, what is the surface marking of the SFJ?
SFJ is present 3 centimeter medial and inferior to the pubic tubercle, lateral and inferior to the pubic tubercle.
Okay, and how will you identify the pubic tubercle?
By assessing the contraction of the adductor longus muscle, you can trace it to the pubic tubercle.
When there is a varicose ulcer, what is the deformity that will you look for?
Equinovarus deformity can happen.
And how is that formed?
It is due to the contraction of the tendon of Achilles.
Because the patient
fibrotic
walks on
changes.
tiptoes because of the pain, and this will cause fibrin deposition in the tendon of Achilles and cause equinus deformity.
What is the significance of a positive Perthes test from a surgical point of view? significance of a positive Perthes test from a surgical point of view.
We don't do Perthes test. In modified Perthes test, if the test is positive and it's suggestive of a deep vein thrombosis, then surgery is deferred until the deep vein system is recanalized.
So coming to the management part, how will you manage this patient?
I'd like to first investigate my patient. Routine blood investigations can be done. Also, an X-ray foot can be taken to rule out any periosteal thickening or bony involvement for the deep-seated infections. And I'd like to go for an imaging duplex scan, which is a combination of a B-mode ultrasound and a color Doppler.
So what all findings will you look for in a duplex scan?
We will initially assess the deep vein. We'll check for compressibility and augmentation, and we'll check for the incompetence or presence of any thrombus. Then we'll assess the junction, that is the saphenofemoral junction, saphenopopliteal junction, for check for the reflex. At the same time, we will assess the great saphenous vein, short saphenous vein, its tributaries, or if there is presence of any accessory veins, that also we'll analyze. And perforator incompetence also should be checked for. A reflex of more than 0.5 second is considered significant in superficial system.
We'll also assess the diameter of the veins.
Yes, diameter of the vein. We can give an idea about the surgery that we are planning. If it is beyond 15 mm, we should consider for open surgery.
Okay.
Okay, is there any other investigation you will go for as completion of your assessment of this patient? Any other investigation?
Like imaging?
Yes.
If we are suspecting any abdominal or pelvic vein pathology, we can do a CT venogram.
Okay, and an ultrasound abdomen just to rule out any other abdominal pathology causing compression. So secondary varicose vein.
So in this case, how will you manage the venous ulcer part?
Venous ulcer can be managed by, there are two schools of thought. Either you manage the ulcer first and go for a definitive procedure for the varicosity, or you manage both simultaneously, provided the ulcer is not infected. If the ulcer is infected, I'd go for IV antibiotics daily C and D. Otherwise, I'll go for a Bisgard's regime, which has 4 E components. First is you educate the patient regarding ankle exercises, care of the foot. Second is you elevate the limb. Third is you give 4-leg compression bandages. And fourth is you evaluate the ulcer periodically. And 4-leg compression bandages can be applied 1 week at a time, and up to 6 applications can be done.
Is there any contraindication for this 4-layer bandage?
Yes, if there is a concurrent arterial disease for the patient, and if the ABPI is less than 0.5, then you will not apply a 4-layer bandage. If it is between 0.5 and 0.9, you can apply a bandage with pressure of 30 mm mercury.
Okay, now if despite your treatment this varicose ulcer persists, how will you proceed? What would you suspect?
So there are two schools of thought. One, we either continue with the 4-layer bandaging and we treat the ulcer first, and then we treat the chronic venous insufficiency with surgery, or we can do both at the same time, depending on the center. So for surgery, we'll give the choice to the patient, because both conventional or open surgery and endovenous surgery have found to have similar long-term outcomes. So we'll explain the procedure, both the procedures to the patient, and give the patient the choice. So if we are picking conventional or open surgery, we'll be deciding to do a Trendelenburg surgery with the stripping and a perforator ligation. Or if we are picking if we are picking endovenous options, then we have either thermal options or or chemical options. So we can either do an EVLA or an RFA, endovenous laser ablation or a radiofrequency ablation, or we can do a chemical options like mechanico-chemical ablations. We can do foam sclerotherapy.
Okay, so your ulcer is a chronic ulcer, so now it's starting to show some changes. So I mean, what would you suspect and how would you proceed? Changes in the sense that the base becomes more indurated and there's raised edges.
If we are suspecting infection, then we'll go for debridement with IV antibiotics.
Okay, I was just asking, like, a chronic venous ulcer can undergo malignant change, so you have to also suspect.
Can develop. If so, we'll take a wedge biopsy. assess it. However, it's rare in the case of a venous ulcer.
In this patient, which is the first option will you give? Trendelenburg operation or management of choice will be?
Depending on the center, we can give the option to the patient. Currently, endovenous ablations are considered better, but long-term outcome-wise, both are the same.
So, what is the principle behind the radiofrequency ablation?
Radiofrequency ablation, the fiber is at a temperature of 120 degrees Celsius, which damages the venous endothelium and causes periphlebitic reaction, causing a thrombosis of the great saphenous venous system.
So we have studied that if endothelium is damaged, it can cause thrombus formation. Then why in RFA there is no thrombus formation?
Actually, RFA.
If endothelium is damaged, we know according to Virchow's triad, if endothelium is damaged, there can be thrombus formation. But in RFA, we are deliberately damaging the endothelium. So we want to create a thrombus or what?
In RFA, after damaging the endothelium, the vein gets obliterated. However, if it can lead to deep venous thrombosis.
Any precaution we take during the procedure to prevent the thrombosis?
We will stay 1 to 2 centimeters away from the saphenofemoral junction, as well as you can inject tumescent around the vein too.
Actually, we are giving extrinsic compression to the vein so that the two walls will get opposed each other. That will prevent the thrombus formation.
Tumescent to give external compression to the vein.
What is saphenous eye?
Saphenous eye is the normal great saphenous vein which is dilated between the saphenous fascia and the deep fascia that we see on duplex scan in the coronal section.
Now about EVLA, what is one of the most fearsome complication of the EVLA procedure?
EHIT or endovenous heat-induced thrombosis.
Yes, heat-induced thrombosis. In which categories will you give anticoagulation?
In 3 and 4, for 3 we'll give for 1 month, and for 4 we'll give for 3 months.
So coming to the Trendelenburg operation, what do you do in Trendelenburg operation?
So the patient is first positioned in the Trendelenburg position with the head tilt of 30 degrees down, and then the knee is flexed with the hip externally rotated, and then we make an incision, transverse or an oblique incision just below the saphenofemoral, just below the inguinal skin crease. After that, we identify the named and unnamed tributaries of the great saphenous veins. The named tributaries medially would be the superficial and deep external pudendal vein, and laterally would be the superficial circumflex iliac and superficial epigastric. And then the distal tributaries would be the posteromedial vein of thigh and the anterior axillary saphenous vein. So after tying all of this, we trace the GSV to the saphenofemoral junction where it pierces the cribriform fascia. Once we have traced it to the femoral vein, we do a flush ligation at the saphenofemoral junction of the GSV. And then after that, we will proceed with a stripping of the great saphenous vein till the knee joint, till the knee joint or just below the knee joint. So this stripping can be done either above downwards or down to up. Both have found to have equal outcomes. So a Meyer stripper or a Codman stripper is inserted into the GSV, and then distally we make another transverse or vertical incision. We pull out the distal end of the stripper, and then we, after applying a compression bandage from distal to proximal, and after addressing the perforators, at the end, the last step would be to strip the great saphenous vein.
You mentioned about flush ligation. What is flush ligation?
Flush ligation is when we ligate the great saphenous vein very close to the junction, so as to prevent any reflux in the tributaries or recurrence because of that.
Any other particular complication if you are not flush ligating the subject?
You are entering to the last minute.
It will cause saphenous varix.
Saphenous
Saphenous
varix
varix will be formed. Now, why will do you do stripping only up to below knee? Why won't you do below knee?
Because the relationship between the saphenous nerve and the great saphenous vein is very close below the knee joint, so it can cause saphenous neuralgia.
In case there is a saphenous nerve injury, it will cause, what will the clinical manifestation the patient will present with?
It present with paresthesia along the medial side of the
Foot and also the leg.
Are there any other minimally invasive procedures for varicose vein treatment? Minimally invasive surgical procedures.
Like foam sclerotherapy or
Endoscopic procedures?
Do a venous seal or a molecular?
We have a subfacial ligation of prostate.
So thank you. I think we have crossed the time. So let us, well done both of you. So let's go to the next team, that is Calicut will be presenting. Slides on, please.
Good morning. We are Team Calicut. So today we'll be presenting a 65-year-old male manual laborer hailing from Koilandi who presented with pain in the right calf for 1 year, wound over the right great toe for 3 months. So the patient was apparently well until he presented with complaints of pain over the right calf for the past 1 year. It was insidious in onset, cramping pain, initially present on walking more than 100 meters, which is relieved on taking rest. Now he can only walk up to 50 meters, after which he has to take rest. Pain is aggravated on lying down and relieved by hanging the foot over the right side of the bed. There is no history of radiation of pain. Pain neither present while taking the first step and not relieved by bending forward. Patient developed a wound over the ball of the great toe 3 months ago. It was initially small in size and progressively increased to the current size. There is no history of trauma, no history of discharge or bleeding from the wound, no history of other wounds elsewhere on the body. There is no history of similar complaints in the contralateral leg, no history of pain over the upper or lower limb in response to cold or warmth, no history of chest pain, transient loss of consciousness, blurring of vision, no history of postprandial abdominal pain, nausea, vomiting or altered bowel habits. There is no weakness or paresthesia of the upper limb, no history of impotence, pain in buttocks while walking. Past history, no history of any previous surgeries, no history of chronic drug intake, no history of diabetes mellitus, hypertension, CAD or bronchial asthma, and no history of previous blood transfusions. Coming to personal history, the patient has a mixed diet, sleep decreased, appetite was normal with bowel and bladder function normal. The patient is a smoker who started smoking at 18 years of age. He currently smokes 20 BDs per day, which corresponds to 47 packets, and he is not an alcoholic. Family history, he is third born of a non-consanguineous marriage. There is no history of similar illness in the family. There is no history of type 2 diabetes, hypertension or CAD in the family.
Moving on to the general examination, patient was examined in a well-lit room after obtaining consent. Patient was conscious, cooperative, well-oriented to time, place and person, moderately built and nourished with a BMI of 21.6, ECOG score of 2. Clubbing was present, but there is no pallor, icterus, cyanosis, generalized lymphadenopathy and pedal edema. Oral cavity, nicotine stains were present over teeth, buccal mucosa and lips. Dental caries present with multiple loose tooth with dentition of 26. Nicotine stains were present on fingernails also. Moving on to the vitals, pulse rate was 68 beats per minute, regular rhythm, normal volume and character, no radio-radial and no radio-femoral delay, no vessel wall thickening. BP, it was 150 over 90 millimeters of mercury measured in right arm sitting position and 140 over 90 millimeters of mercury in left arm sitting position. Respiratory rate of 14 per minute, abdominal thoracic, and the patient was afebrile. Local examination, patient is examined after informed consent with adequate exposure in a well-lit room. Inspection, the attitude of the limb was hanging from the bed. Right leg appears pale and thin compared to the left. There was bilateral loss of lower limb hair and shyness was present. Toenails were brittle. A single oval ulcer of 2 into 1 centimeter was present over the plantar aspect of the right great toe, punched out edges and irregular margins. The floor of the ulcer, there was slough present with serous discharge, non-foul smelling. Surrounding skin was dry, hairless and shiny. Burgess postural test, Burgess angle was at 45 degrees, capillary refill time at 4 seconds noted on toes of right foot and venous refill time of 3 seconds noted. Palpation, right leg colder than the left leg, no tenderness of right lower lip, limb a single oval ulcer of 2 into 1 into 0.5 centimeter with punched out edges and irregular margins over the plantar aspect of the right first toe, base indurated with non-bleeding on touch, no fixity to underlying bone. All the peripheral pulses were palpated. Carotid artery, superficial temporal artery, facial artery, brachial artery, radial artery, ulnar artery and femoral artery were palpable bilaterally. Popliteal artery was not palpable on the right side. Anterior tibial artery, dorsalis pedis artery, posterior tibial artery were not palpable bilaterally. Cross-leg test, absent pulsation was noted on the right leg, no palpable crepitus over foot. Bilateral lower limb shows loss of hair and thinning of skin. Limb girth at thigh was 48 centimeters on right side and 50 centimeters on left. And limb girth at calf 28 centimeters on right and 30 centimeters on the left. Movement of right lower limb, interphalangeal joints, tarsophalangeal joints, ankle joint, knee joints and hip joints were normal. Neurological examination, decreased sensation of touch and pain over right foot compared to the left. Other sensory tests seem to be normal over bilateral upper and lower limb. Power grade 5/5 in bilateral upper limbs, power grade of 4/5 in right lower limb from knee down and 5/5 in left lower limb. Deep tendon reflexes and superficial tendon reflexes were brisk except for bilateral angle jerk reflex which was absent. Lymph node, no palpable bilateral inguinal lymph nodes, and on auscultation, no bruit over bilateral carotid, subclavian and femoral vessels. Other system examination, cardiovascular system, first and second heart sound were normally over precordium, no raised JVP, no murmur. Respiratory system, trachea central, normal vesicular breath sound heard in all areas, no added sound. Per abdomen, no abdominal distension, non-tender and soft, no mass per abdomen, no organomegaly, and bowel sounds were present. Central nervous system, higher nerve, IM under functions normal, no focal neurological deficit. Skull and spine, normal.
So a summary, the patient is a 65-year-old smoker presented with claudication pain in the right calf for 1 year with wound over the right great toe for 3 months, which is progressively worsened with features of peripheral arterial vascular disease. This is possibly due to right femoropopliteal atherosclerotic obstruction with an ischemic arterial ulcer over the plantar surface of the great toe.
Yeah, that was a good presentation. So initially you had told that a patient is having claudication pain, but you didn't tell us where the claudication pain was, until what level it was. Could you just clarify us on that?
So the patient developed a claudication pain mainly in the calf region and calf and below, and the patient will worsen as in the claudication distance reduced over the past 1 year.
And you mentioned clubbing as well. Could you tell us how it is significant in this patient?
The patient is a smoker, so its relevance is because of smoking. It causes clubbing in this patient because of increased blood flow to the peripheries.
So from your history, what are the points in favor of an arterial disease? From your history, the points in favor of an arterial disease.
Okay, so in our case, so is a age 65-year-old male who has claudication pain. So the claudication pain and also worsening claudication pain with a wound which is non-healing, and the wound is particularly over the ball of the great toe, which is a pressure point, a site of trophic changes, and also the patient has neurological changes.
Okay.
There's neuropathy.
Okay, you said claudication pain. It should be reproducible also. That is one of the features of arterial disease. So can you tell me in which stage of an arterial disease the claudication pain relieves on further walking?
We have a classification called as Boyd classification. In the case of grade 1,
Okay.
there is actually
Good. Okay. Please continue.
Yeah. So in the case of grade 1, the pain decreases on further walking, and in the case of grade 2, the pain persists, and with effort you'll have to walk.
Okay.
And in the case of grade 3,
can you
there
tell
is.
me why the pain decreases on further walking in grade 1?
What happens is the reason for pain is because of the accumulation of a substance called a substance P. So what happens in the case of grade 1, there will be washout of there will be vascular dilatation, and there will be washout of the substance P.
Okay, thank you.
What is the newer term for critical limb ischemia?
Chronic limb threatening ischemia, CLTI, is a new term.
Can you define it? Can you define chronic limb threatening ischemia?
It's a rest pain that is present for more than grade 2 weeks with this ABBI less than 0.5 and angle systolic pressure less than 50 and toe systolic pressure less than 30 mm of mercury.
It also includes, other than ischemic rest pain, it also includes presence of an ulcer.
So, do you know what pseudoclaudication is? Have you heard of the term pseudoclaudication? It is usually another term for neurogenic claudication. Can you differentiate between neurogenic claudication and arterial claudication in your history?
Actually, patient will have claudication cramping like in arterial disorders. Patient will have a cramping pain as we mentioned in our history. But in a neurological claudication, patient will have shooting pain. And in arterial claudication, the pain will disappear on taking rest, whether standing or sitting. But in a neurological claudication, patient will have to sit or bend forward to relieve the pain. It will not be relieved on standing.
And it takes a longer time to relieve the pain in neurogenic claudication, and it will be present, there will be no claudication distance as such in a neurogenic claudication. Okay, so on examination, can you tell me the features of an arterial ulcer? Yeah, arterial ulcer.
So the ulcer will have a raised, punched out edges. With also on peripheral examination, you'll see that there will be an absent pulsation, and it will be a chronic changes. So it will be a chronic non-healing.
Skin changes will be there, shiny skin with loss of hair.
Margin with bluish.
Also the arterial ulcers are deep ulcers. It can involve the underlying tissues. So you did the Burgess postural test. So how did you perform the test and what is its significance?
So in the case of Burgess postural test, we ask the patient to raise his leg. So the angle at which we notice a pallor, so it's creating an angle with the bed. So that angle at which we notice a pallor first is called as the Burgess postural angle. So the significance is that once this angle is very less than 30, we can see that there is a
pallor as well as pain. The patient might develop pain. So can you tell me what a sunset foot sign is on inspection?
So in the case of sunset foot sign, when we are placing the leg in a dependent position, there is actually a return, pinkish return of the color.
Yeah, it will look like a cellulitis picture almost, and on raising the leg, there will be guttering of pain and a pallor. Okay, so can you tell me, say your history is strongly suggestive of an arterial disease, but on examination you are getting feeble pulses. Is there anything else you can do clinically to further bring out that it is an arterial disease?
If you are suspecting an arterial disease, and you can ask the patient to do some exercise like walking, brisk walking or running.
Yeah,
and
there's a name test. Do you know? It's known as a Greenhow 1-minute walking test. The patient is asked to walk for a minute, and if the pulses disappear, what is it called? What is this phenomenon called?
Disappearing pulses.
Yeah, disappearing pulses. And you know why disappearing pulses happen?
So there will be so the distal runoff is present. That is, there is patency of the distal blood flow, and so there will be collateral circulation formation. So when the patient starts exercising, there will be loss of this collateral blood flow because of increased consumption of the blood flow by the muscles. So there will be disappearing of the pulsation.
Actually, when there is a proximal obstruction which is not completely obliterating the vessel, during exercise there will be a distal vasodilation which will unmask the disproportionate flow. Okay.
So after arriving at your clinical diagnosis, how will you investigate your patient?
Okay, so clinically, so on the bedside, a very useful tool we can use is the handheld Doppler, which we can use to assess the ankle brachial pressure index, which is also a quantitative assessment of.
Okay, before that, would you like to do look for a complete blood count, basic investigations? How is it significant?
So complete blood count and investigation is needed because we'll have to assess for the diabetic status, lipid profile, which will be a predisposing factor in this case.
Would you like to go for a ECG, a bedside echo? Is it important?
Yes, because in this patient especially, the patient has claudication. So claudication is an important marker of cardiovascular morbidity, which is important for treatment.
Do you know the association? What is the percentage of cardiovascular risk in terms of ABPI?
For every 0.1 decrease from 0.9 we will have a increase in 10 percentage
Yeah, good.
cardiovascular.
Okay. So after that you mentioned ABPI. So how do you do ABPI?
So ABPI is the highest systolic blood pressure measured in the ankle versus the highest systolic blood pressure measured in the brachial artery.
So what is the cutoff for chronic threatened limb ischemia?
Less than 0.3 will be for imminent necrosis.
0.4.
0.5 is respiratory.
So if at all your ABPI is coming as 1.4, would you like to go for any other test?
So this is indicative of calcification of the.
It is an indication that the arteries may be calcified, especially in diabetic patient. Then in that case, we can go for a brachial toe, TBI.
TBI. So why you go for TBI? Why?
Because the toe arteries, they are usually not they are usually spared in diabetes. And
So after that, which investigation would you like to go for?
So we would go for a duplex scanning, which is a beam mode ultrasound plus a Doppler.
Okay. So what are the findings you are expecting?
So there are 3 findings which we get in a duplex scan. There can be triphasic, biphasic and monophasic. In the case of, in our case, it could be a monophasic, or if its obstruction is partial, we can have a biphasic because there is no backflow in the second phase is not there. And monophasic when it's completely occluded.
Anything else you look for in arterial Doppler? You should check for the percentage of stenosis, if there is distal runoff, if there is presence of collaterals also. And around a 50% stenosis is significant for monophasic flow. So then would you like to consider a CT peripheral angiogram?
In our case, we would like to consider a CT angiogram or MR angiography.
Okay, suppose your patient, you're going for a CT peripheral angio, you will assess the renal function. The creatinine is found to be 1.6. So would you like to, how will you optimize your patient before the CT scan?
So we would preload the patient with fluid because the contrast is the cause for nephropathy. It is drug-induced nephropathy. So before the procedure, we have to give IV fluid, and even post-procedure, we should give IV fluid and monitor the output, urine output.
Okay. You should also avoid nephrotoxic drug. There is a role for, in diabetic patients, metformin should be avoided. That also can be mentioned. So how will you stage your limb? Is there a classification?
So the classification, there's a Fontaine classification and there's a Rutherford classification. So as per the Fontaine classification, this patient has ulceration.
Okay. Is there a better classification than these two? Have you heard of the Wi-Fi classification? So what are the components of Wi-Fi classification?
So it will be, so the components includes wound infection, tissue loss and ischemia.
And
so
foot function. Okay. So after grading your ulcer, grading your limb, how will you proceed?
How will you proceed with management?
So if we are planning an intervention, so okay, so
So in this case, our patient is a smoker. So the first advice that we have to give is stop smoking. Then only if, we move on to the other management. So we advise the patient to stop smoking, and then we move on with, we will ask the patient, modifiable risk factors could be managed. So we ask the patient first to walk for brisk walk, like 40 to 60 minutes of walk for 3 days a week for approximately
so,
3.
your patient is having rest pain,
Yeah,
right? So is it actually possible to do this?
No, we don't have rest pain in our case. So if at all possible, we advise that. Then also we ask for weight reduction as well as dietary modification, and then we'll have to move on with
So it
other
should be a
pharmacological
supervised
management.
program.
Yes.
Okay.
Then we'll have to move on with pharmacological modalities.
Okay, so before that, of course, we need to treat the disease, but we also need to treat the pain, right? Which the patient is
Yes,
presenting.
pharmacological modalities. We will have to go with analgesics. We usually try to avoid opioids, and we'll also give it
Okay, so what medical management would you prefer in this patient? What medical management are you going to give?
okay, so medical management. So this patient, we would start the patient on statins. Also, as per the NICE protocol, 75 mg of aspirin or 75 mg of clopidogrel. There's currently they state that vasodilators can be given, but it's not of much significance in the current treatment.
Okay.
And also, I mean, you have to control the diabetic status. You have to control.
And statins, how much do you want to give? You want to give a low dose statin or a high dose statin? What do you want?
high dose statin is usually recommended in this. like 40 milligram of atorvastatin once at night, or a rosuvastatin 20 milligram at night.
Okay, fine. So let's say that you've done a CT peripheral angiogram and you're getting a task class A lesion. So how would you like to revascularize your patient? You've done a CT peripheral angiogram, you're getting a task class A lesion. How would you like to revascularize your patient? Basically, you're getting only a single segment occlusion or stenosis.
So basically, if the lesion is shorter segment as well as if it's more proximal, we can go with an angioplasty or stenting. Once it is too large, we will have to, once the segment is too large, we'll also have to assess for the distal, we will have to assess for the run-in as well as distal runoff. We can also go with bypass.
So what type of stents are available? And which is better? Which is considered better?
There are endogenous stents and synthetic stents available. You can use a reverse saphenous graft.
No, I'm asking about stents, not grafts.
So there'll be self-expanding stents, and also there could be drug-eluting stents. But
So which is better? Is the
drug-eluting
stents are better. Could you tell us why?
Drug-eluting stents prevents rethrombosis of.
It prevents neointimal hyperproliferation. Okay, so let's say it's a task D lesion and you're going to do an open bypass. So what options do you have for grafts?
So we have natural as well as synthetic. So in the case of natural, we can go with saphenous, reversed, or in the case of synthetic, we have Dacron as well as PTFE, in which PTFE is better compared to Dacron.
Both are available, natural and synthetic. Which would you choose?
Always natural first, followed by synthetic.
Yes. Why? Do you know why?
Because natural, in the case of natural, the thrombosis rate is seen to be lower when compared to that of synthetic ones.
All right. So let's say you've done a bypass for a patient. Immediately post-operatively, you found that patient is having a good popliteal pulse, good anterior tibial pulse. Then when you go for evening rounds, you see that the popliteal pulse is absent, limb is slightly cold. What will you suspect?
We would suspect thrombosis of our graft. So
okay, and how will you manage this patient? It's an acute thrombus, right? So you will want to take down the anastomosis. You want to do an embolectomy with the Fogarty, right? All right. Now let's say your patient is having a non-reconstructible limb ischemia, as in revascularization is not an option. In that case, how can you treat your patient? As in, you've done a peripheral angiogram, you found that you cannot reconstruct any of the arteries. So then how will you manage your patient?
So there will be
Time's up.
pharmacological therapy. Also,
You can use prostaglandin infusions, okay, and stem cell therapy is a newer modality that you can use for.
Okay, thank you so much. We'll just stop now. We'll have come, all of you. Congratulations, well presented. Now I request Rajan sir and Dayanand Babu sir to pass your comments and.
Regarding the varicose veins, the examination should have mentioned about the lower abdominal veins. You have mentioned abdominal examination, not about the veins in the lower abdomen. That you should have. Yes?
Sir, we had mentioned that in inspection, so we didn't include it in the...
Abdomen you have mentioned, but not that. Then why you are saying that this is primary? Why not secondary?
So, there's no secondary cause. We are not able to...
Need not be there, because there may be hematological causes. You don't know. How do you rule out a
so
DPFA?
based on history, we had ruled out a DVT, and also on examination, we ruled out any abdominal masses, pelvic masses. So clinically, we thought it would be a primary cause.
No. Localization of saphenofemoral junction is mainly by ultrasound, finally. Sonologically, you locate. And how long it will take for recanalization of the DVT? Somebody said after recanalization, we will do surgery for varicose veins.
So
how long it?
Recanalized deep vein thrombosis is currently a relative contraindication. So we can offer
No,
based on...
it is a contraindication. But recanalization will take a long time. Your answer was, you wait for recanalization and after that you do surgery. What is the correct terminology, varicose ulcer or venous ulcer?
Venous ulcer.
Eh?
Venous ulcer.
Venous ulcer. Most of the time, both we are mentioning about varicose. And the venous ulcer, which one you will treat first? The ulcer or you treat the varicose veins?
So there are two options. We
Yeah.
can either treat the ulcer and then treat the vein, or we can do both at the same time as long as the ulcer is not infected.
What is the primary treatment of ulcer?
So it is 4-layer compression bandage.
It is compression therapy only.
Ah.
Of course, it depends whether, but main treatment should be directed towards the, and where, what is the incision for the Trendelenburg? Incision.
We make a transverse or an oblique incision just below the inguinal skin crease.
It should be at the crease or above. That is the current. And no mention was made about the treatment of perforator. And you people didn't ask
So,
also.
While stripping, I had mentioned that before we strip the veins, we'll do a multiple perforator ligation.
And the new treatment, somebody asked what is the new endovascular, you didn't answer. What is it? The glue is there. Glue is coming in a big.
Mechanical ablation.
And the mocha also.
Mocha.
That you should have mentioned. Glue and
I say.
mocha.
We mentioned.
Okay. And regarding the POVD, the peripheral, the order of palpation of the pulse is how? From below up or above downwards? You have mentioned from above downwards. So it is peripheral vascular disease.
Yes, sir, yes, sir.
So
Below
you,
upwards.
which is the order?
Below upwards. From below upwards.
Yeah. But the neurological examination, you started with neurological examination. Why?
Also to assess the neuropathy of the patient.
Neuropathy, you go for neurological examination. Did you mention about the sensations and type
Yes, sir.
of?
Yes, sir. We had mentioned the sensation,
that
movement,
is there.
power.
And the claudication, just calf muscle alone was. Whether is there any thigh muscle claudication? Is there any gluteal claudication? Those things were not elucidated. From the, if you elucidate the claudication, then we know the level of occlusion. No mention, maybe Larish, but no, you said no Brui. And the Boyd's grading, she asked some grading and you said, that is Boyd's you mentioned, isn't it?
Boyd's classification.
Boyd's only, yeah.
Now to Team Kottayam, you mentioned about the examination of cardiovascular system. The routine, S1, S2, blah, 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 blah. What is the importance of examination of the cardiovascular system in terms of varicose veins?
So any congenital, like Park-Weber can have high output cardiac failure, AV malformation causing a high output cardiac failure.
Mm-hmm. Anything else regarding the varicosity? Dilated veins.
There can be bruit over the varicosities. Right heart failure can occur as a...
Yeah, gross tricuspid incompetence, perhaps more significant in bilateral disease. Okay? Now, regarding the PVOD, did you look for any thrombophlebitis?
Yes, sir. We had looked for thrombophlebitis,
You
superficial
did
thrombophlebitis.
not mention, but what is the relevance?
Sir, in Berger's disease, there will be involvement of the venous system also causing superficial thrombophlebitis.
Yeah, it's a panarthrophlebitis, isn't it? Yeah. Why is it called claudication? Why don't you just call it pain? Why do you call it claudication?
It's it derived from a word called as claudio, which means eye limb.
Pardon?
Eye limb.
Eye limb. Also, it is reproducible and which is relieved on taking rest.
No, it's something related to Claudius. It's Julius Caesar character. Claudius, person who walks with limping. Right? All right, thank you. Well done, both teams. Very well done, thank you.
First of all, congratulations to both of you. You presented reasonably well. I just want to pass certain comments, not more any more questions, because already been asked between yourself, and I think the two great teachers have also asked you a question. Just few observations I just wanted to share. One thing is about presentation side. I found, especially when you present, you try to speed up on certain critical areas. That's what I felt, especially on the side of when the delegate was presenting. And there are certain areas when in specific topics like varicose veins as well as in POVD, past history, it is just not the mention of just like Rajan sir was saying, it is like no history of hypertension, diabetes, CAD and all. Another thing which could have been added on was probably the previous intervention, because this is an era where you have a lot of intervention being done. And that will be a clue regarding what has been happening. That is one thing which I wanted to say. So I would like that advice, when you present, try to slow down on critical areas and then put it across. That is one area. Second thing is, what I found was in the whole process was, regarding when you were quickly jumping into the usual in clinical discussions, and when you test want to know to knowledge. Of course, you have only 15 minutes to ask. There can be a lot of things could have been asked in the history and examination side. You jumped into management side and then went on to ask about complicated management side, which may not happen in normal, because when Dayananda Babu sir and Rajan sir were our teachers and we were examining, we never reached the level of advanced treatment option. We stopped with probably maximum you can reach is investigation, then the final, because the whole examination goes in that level. So I think you were jumping, of course, you were all answering reasonably well. That is what I want to say. I was just asking, you were discussing about, when you discussed about the ulcer we had, you were saying a punched out and everted edges. That I just one or two points, because I have a lot of points which I don't want to go with the lack of time. What do you mean by that? In that ulcer, what was your point you wanted to convey? Because it got me confused what you were talking about. You said the ulcer was punched out and everted.
So we...
Raised, not everted, sorry, raised, that was what you mentioned.
Punched out to indicate that it was an arterial ulcer, and raised indicating the chronicity of the ulcer.
Okay, that's fine. So those are the points which I wanted to highlight on that issue. So both of you have presented well, congratulations, and we will wait for the results later on. Thank you so much.
Thank you, sir.
Thank you very much. Congratulations, Team Kottayam and
as we conclude, since it's an examination session, we conclude it at the moment. Thank you.
Thank you, sir.